Well, welcome to San Diego, everyone. My name is Tim Morris. I'm co-chairing the meeting along with my friend Peter Gay. Ever since the first time walking into the hospital as interns, most doctors are haunted by the possibility of having to utter two of the worst words in medicine, and those are, if only. If only we had gotten that x-ray, if only we had checked that lab, if only we had started therapy only a little bit earlier, if we had admitted that patient to the ICU, if only we had done that, if only he had not gone home that day, if only we had known, we would have acted sooner. The focus of this conference is on that time that we would call sooner. For those of us in the pulmonary field, sooner is defined as that window of time prior to respiratory failure, and we coined the phrase respiratory compromise. And respiratory compromise is a state during which the risk of respiratory failure is high. It just hasn't happened yet, and there's still some opportunities to intervene and prevent it. Our theme today and tomorrow is to work together to optimize those opportunities that we would have before respiratory failure occurs. We've assembled a multifaceted group from academic medicine and industry to address the problem of respiratory compromise and importantly offer some real-world solutions. We hope to publish the results of these proceedings, which will be similar to the proceedings of a similar conference that we had back in 2017 in Florida, where the entire idea of respiratory compromise was formulated and the phrase was coined. Our discussion during that conference concerned the heterogeneity of patients in respiratory compromise and the variety of pathways that might lead to respiratory failure. For example, patients with pneumonia decompensate very differently than those with asthma, and those decompensate very differently than those with pulmonary embolism. However, we recognize the possibility that groups of patients with similar pathophysiologies and similar risks might be monitored and treated similarly. It is to that end that we're meeting here in San Diego today. Let me show you the schedule. So that's me up there. So we're going to hear from Wes Ely, who is a world expert on delirium, the fifth vital sign. Frank Overdyke is going to talk about respiratory event monitoring. Brooks Kuhn, unfortunately, could not be here today because of a family emergency, so I'm going to fill in for him and talk a little bit about train wrecks and asthma. Jerry Kreiner will talk about COPD exacerbations and the risks that they suffer. Peter Gay will then talk about catastrophes from missed obstructive sleep apnea. Mike Niederman will talk about pneumonia heading for the cliff, and then Peter will wrap up tomorrow's plan. We left out this other guy, Tim Morris, I think is going to be here talking about pulmonary embolism. He's somewhere in there, I think. I don't know why we're not advancing. That's all right. Then the next day, we'll have Dr. Namadi is going to talk about artificial intelligence, and then we'll have a common group presentation to discuss possible pathways forward. So with that, let me finish. I'll introduce my co-chair, Dr. Peter Gay.
So thanks a lot, Tim, and thanks everybody for coming. I put this down to a normal human height range here. Obviously, everybody made an effort to come here because they have expectations of, I think, partly just seeing some of the names that are with us here and understanding that the people here could make an impact. That's what we're here to do, not just to listen and say, oh, that's kind of cool, and maybe I'll do something with that. But with information,
can you hear me? I'm ready to go.
Understanding that we can find a lot of this stuff, but there's
Jason?
Still going to be disasters that happen, and how can we not get there? So it's my
Can you hear me?
pleasure to introduce Wes Ely, who's going to be with us by
Are y'all
Zoom.
ready for me to start?
Unfortunately, he had an ailment that wouldn't put him on an aircraft today, but he's agreed to share his
Recording in
expertise.
Progress.
Virtually everybody has heard of Wes Ely and his profound
Are you all ready for me to
understanding
start?
of the fifth vital sign, as we now call it. Second, or sometimes the first.
I can't hear y'all anymore. I could earlier.
Okay, well, it sounds like he just wants to go at it. So here's Wes Ely from Tennessee talking to us about delirium, the fifth vital sign. Have at it, Wes.
Okay, fantastic. Morning, everyone. My name is Wes Ely, and it's a privilege to be with you today. I can tell that this is going to be a very exciting conference. And it's a privilege to play a small part in this great scientific exploration that you're going to be going through over the next 2 days. My talk is going to be entitled Delirium, the Fifth Vital Sign. I am a physician scientist from Vanderbilt University, and I've been studying this problem within the human body for about 30 years. And I know that there have been lots of things proposed to be a new vital sign. Few of them, though, are the strongest predictor of death in the ICU, the strongest predictor of long-term brain function or dysfunction after survival. And few of them are such a striking way of understanding what is going to contribute to excess resource utilization down the line for human beings who are undergoing critical care in our ICUs all over the world. Delirium meets all of these things which I've just said, and so indeed is a legitimate candidate as the fifth vital sign. I do not have any financial conflicts of interest from the industry perspective. I am NIH and VA funded. I have explicit written permission to share the patient's stories and pictures that I will share during this talk. And the only industry related thing I will mention later is that when we get to COVID conversations, I'll talk about the role of baricitinib, a JAK-STAT inhibitor, in becoming the first immunomodulator approved for life-saving benefit in acute COVID. And now we are launching a large $30 million NIH-funded investigation of baricitinib, this same JAK-STAT inhibitor, for immunomodulation in long COVID. So we'll get back to that. This is one picture of about half of our SIB center. It's hard to get everybody together on the same day. But what I wanted to share with you is that we have just people from all walks of life who have come together to be part of this discovery process at Vanderbilt and the VA. And we have metastasized all over the country in terms of scientists doing these 40 or 50 ongoing randomized controlled trials and cohort studies that we do through the CIBS Center, which is Critical Illness, Brain Dysfunction, and Survivorship. And we're so involved in things outside of critical illness now that we're really thinking of renaming ourselves to something about acute care recovery, a recovery from acute illness, because we deal with long COVID, for example, as an example of an illness, a disease state, which most of the patients with long COVID-related brain injury were never even hospitalized to begin with. So if you divide critical care into two 25-year periods, the first 25-year period was a period of construction, building, adding, complicating. But the second 25-year period is the one I'm going to talk about today, and it's a period of deconstruction. I'm going to tell you the story of the second 25 years and how it played into the COVID pandemic most recently. Now, I like to tell stories. And what I'm going to do today is utilize the power of human story to get across some points that I think will be the take-homes. And the take-homes are going to be these. What if I told you we knew how to do a better job at caring for others, but we don't do it? And that all it requires is us recognizing that we're called to an encounter with another human being. So how do we do it? We wake people up. We get them out of the bed. We walk them on the ventilator. We consider them as an entire human being rather than a set of lungs that have gone bad or a heart that's gone bad. Now, this is so obvious that it sounds trite to say, and yet, when we get in the ICU, I'll just speak for myself, I know that I dip back into my old way of doing things, which is catheter numbers, beeps, buzzers, pulse oximetry numbers, and not thinking about the whole person lying there in the bed. So Teresa Martin, and again, I have permission to use all the pictures, names, real names of the people in this talk today. She was a patient of mine who was on the ventilator in her 20s, had ARDS, and when she was on the ventilator in the 1990s, when I was in training, she was paralyzed in a coma, receiving gargantuan amounts of benzodiazepines and morphine every day. And I wrote her story. I included her story in this book that I wrote called Every Deep Drawn Breath. You can see me holding up the hard copy here. The paperback copy is shown on the slide. This book, by the way, every penny from this book goes back to patients and survivors. So it's a book about human beings, real people, using their names and stories to try and raise awareness of and an endowment so that we can provide support for people after they survive critical care. That's what we're doing. Every day of the week, we have free support groups available through our SIB Center for people from anywhere in the world. And they log on from Japan, Europe, Latin America, all across the United States. And we provide a community for them to cry and scream and yell and give each other tips and find a place so that they don't end up resorting to hurting themselves or getting abandoned by their family, etc. The way that Teresa was treated, back to the slide, I now consider malignant normality. I treated her in a way that I thought was normal, but which was as dangerous as malignancy. And it's been my own process to figure out how to undo that. A few years after I cared for Teresa, I designed with my mentor, Ed Haponic, you can see him here as senior author, and a bunch of other residents and fellows, this investigation, which was published in the New England Journal of Medicine in 1996. And basically what this study did was, it was my attempt to say, how do we get back to the person faster? How do we wake up to find this human being again instead of just treating them like a lump on a log in a bed on a ventilator? And so the first step for me was spontaneous breathing trials, just turning the ventilator off every day. And what does that do for us? It takes 2 days off the time on the ventilator. It cuts complications in half, and it saves money, $5,000 per patient. Then a few years later, J.P. Kress, instead of turning off the ventilator, he turned off the drugs, the sedatives, the lorazepam, morphine that Teresa was on, or modern day, the propofol and the fentanyl that somebody might be on. And in doing this, J.P. Kress and Jesse Hall took 2 days off the ventilator and cut complication rates and so forth. So we thought, wow, maybe there's a way that we don't have to put people through a depersonalization chamber. And if you look at the left of the slide, you can see that a human being, a single person, comes in bright colors. And then in critical care, we depersonalize them down into this gray zone world. And indeed, on the right of the slide, you can see we do this for the whole population. They come in their greens, their magentas, their oranges, their yellows, and then we gray, 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 gray. By putting them in a bed, sedating them, and thinking that our job is life support. No, our job is not life support. That's a tool we use to find the person again. And so in my own chest pain world of feeling guilty and feeling shame, knowing that I wasn't doing right by my patients, I sought out a newer way of critical care. And it began with trying to say, well, Wes, as a non-gray-haired intensivist, you're thinking through this. If somebody's delirious, then I've lost them out to sea. They're gone from me. If their brain isn't working, I can't know simple things like their favorite, the 4 questions I ask all my patients now, or their families if the patient can't answer. What's his favorite music? What's his hobby? What's his pet's name? And what's his favorite food? If somebody's delirious, they can't tell me that. And I can't get even deeper into perhaps their spiritual values or what matters to them about relationships and that sort of thing. So we invented a tool called the CAM ICU. It was reliable and sensitive and specific. We then took the idea that consciousness is arousal and content, and we were paying attention to arousal, but not well. We were using, at the time, the Glasgow Coma Scale, not even validated outside of the trauma or neuro ICU, but we had applied it over to surgical, medical, burn, et cetera, ICUs. So we took part in working with Kurt Sessler from Richmond, Virginia, and creating the Richmond Agitation Sedation Scale. And then we put the two things together and we found that delirium was not just associated with mortality, but was a predictor of mortality. That this set of tools, the RAS and the CAM, could measure if somebody was present cognitively, and if they weren't, that they had a doubling of the likelihood of dying. And if you actually put it on a Kaplan-Meier curve and you look up at my hand for a second, this is a brain totem pole. You got normal, and then delirious, and then coma. The more that they're down here, the more they go down in the red zone on this Kaplan-Meier curve. We don't want people with increased likelihood of dying. We want them to survive. We want them to be up top near the green zones. But how do we do that? So I was focusing on this world of delirium, and all my mentors were telling me, except for two, were telling me, this is dumb. It's not for academics. You'll never get a grant. And they were right about the fact that getting grants was super hard. The first 4 or 5 years that I wrote grants for this, it was just consistent pan. Go away, dumb idea, don't come back. But right as I was about to quit, this woman came along in the stripes. Her name was Donna Hilly. And her sister in white here, Diana Wittenweil, was the chief delirium nurse for all of Kaiser Permanente across California, so where you are. And Diana wrote to me after Donna had been in the hospital, and she said, after she developed delirium, we couldn't get her mental clouding cleared for months. In every deep drawn breath, I abbreviated EDDB, every deep drawn breath, which is from Steinbeck's East of Eden, by the way, an amazing book that he won the Nobel Prize for, and he eventually won a Nobel Prize, the Pulitzer and the Nobel for this literary work. Via Diana's comment about her sister Donna, I began to take seriously that what we were doing in the ICU wasn't just depersonalizing people. It wasn't just removing my ability to see her at that moment. It was actually committing her to a new disease process, which would take the shape of dementia down the line and change the entire course of her life. I started noticing in journals ads like this: diffuse anxiety, infuse Versed, for the continuous calm in critical care. You know, they're almost like I was sleepwalking, and my colleagues were as well, into this just zombie land of, oh, it's not dangerous to put people on tremendous amounts of sedation. It's what we ought to do to protect them. And at the beginning of EDDB, I didn't plan on doing this, but I think I'm just going to read to you something that I wrote at the beginning of this, because it's important to admit when I'm wrong. I wrote this: early in my career, I strayed, not intentionally, but out of a desire to control every medical circumstance. I didn't listen well enough. Our greatest treasure is found in deep, real communication with each other. When this is nurtured, especially in times of suffering, two people can establish something of almost mystical quality, a reciprocal connection that brings us to a place of charity and empathy that crosses cultural, social, and racial boundaries. But without such communication, we remain miles apart. That's what I was doing in my life. And as Thomas Paine wrote in Common Sense, a long habit of not thinking a thing wrong gives it a superficial appearance of being right. So, how did we begin to climb out of this? What we did was we said to ourselves, you know, we have to have science. But clearly, what's bothering me is an absence of humanism. What's bothering me is distancing myself from people. But to bridge that distance, I'm going to have to use science, or the medical field won't change. So we designed studies like this one, published in JAMA, the MEND study, like mending the brain. And we pitted against the benzodiazepines, GABAergic drugs, which are shown in gray. We pitted the other classes of drugs, in this example, alpha-2 agonists. So the GABAergic drugs, benzos, alcohol, propofol, hit the VLPO by being GABAergic, and lower down in the brain at the locus coeruleus, we can hit the alpha-2 receptors with a drug like dexmedetomidine, for example, or clonidine, for example. And when we do that, we showed in this randomized trial that we have a lot less delirium. And in fact, we actually see trends towards improvement in survival. So at the end of this study, we knew some things. We knew that ICU delirium by other papers I didn't show you, was independently increasing mortality. We knew that more delirium was higher mortality. There was a dose response. Benzos were increasing delirium, and we needed to reduce the incidence and duration of delirium and essentially get people off of ventilators faster. To do that, we took the original 2 New England Journal papers I showed you, our SBT study and our SAT study, spontaneous awakening trials and spontaneous breathing trials. And when we put them together in this study called the ABC study, Awakening Breathing Control Trial, we were shocked. I mean, I thought there would be benefit, but I had no idea that we would see a major mortality advantage at the end of 1 year. Nobody had ever shown this before. We had never seen that changing sedation and waking people up and getting them off the ventilator would save lives like this. So, in fact, in the original trials, the 2 trials, remember, it was 2 days less in the ICU. Well, in this case, it was additive. 2 + 2 = 4. We had 4 days less in the ICU. And then we had an additional finding, which we didn't have in the original 2 New England Journal papers, that there was a 4-day reduction in hospital length of stay. This was very striking. It was statistically significant, and people started paying attention. But then I got back to my thoughts about Donna Hilley and Diana Wittenbyle, and she said, she essentially wrote, "My sister is a very old woman now. She can't think." So I started designing this trial, which was in the New England Journal in 2013, which was, give us $9 million, and we're going to go see if after critical illness, after usual care in the MICU and the SICU, do people have dementia? And on this slide, you can see, yeah, they do. These box and whisker plots are down there by TBI and AD, which is traumatic brain injury and Alzheimer's disease. And these people didn't come in with that. These were surgical and medical ICU patients that we excluded pre-existing dementia. And not only that, it was happening in 30 and 40-year-olds. If you look on the far left of this graph, you can see that those who were in their 30s and 40s also had this problem that a year later, their brain function was not normal. And the most striking graph in the whole paper is here. Delirium on the x-axis shows a dose response, so that the longer the person was delirious, the worse their brain function was at the end of a year. Now, when this happened, we started saying, well, what's going on then? Could it be that the brain is changing? And we started doing MRI studies and finding, yeah, that's exactly what we're seeing. We're seeing that there is atrophy, shown on the right in B, with a larger set of ventricles there. You can see that blackness in the middle of the brain is larger than the one on the other side, the A, with the patient with no delirium. Now, this is an anecdote, but it played out across the study that the VBR, the ventricle to brain ratio, was larger depending on how much delirium you had. So that isn't chicken and egg. I can't prove causation via this. We can only prove association. Now, earlier we proved that delirium was a predictor of death, and delirium was a predictor of brain dysfunction. That word predictor is a much stronger word than association. In this slide here, I'm only using the word association. People started writing us these letters. I mean, we have tons of these on our website, which is icudelirium.org. Feel free to go there. On the website, we have tons of testimonials like this. This man says, "My wife of 36 years told me I was just feeling sorry for myself. I nearly ended my life." And many of our patients do end up dying by suicide, which is just absolutely heartbreaking. That's why we use the money from EDDB to create these support groups and hire social workers. And we are paying these social workers out of that salary so that they can be present with a psychologist to talk these people through all this. In fact, we just got a very generous donation from a long COVID, a family of a person who had long COVID who died by suicide. And that family has just given us over $500,000 to keep this process going. And what is that process? Read at the bottom. He says, "From that report, I found your website. I cried. It has changed my wife's opinion about me. For the first time in 5 years, I believe I have a future." We want people to find hope. We want them to remember that no amount of disease can ever reduce their value as a human being. That every human being is of inestimable value. And that it doesn't matter if you have cancer, sepsis, if you have new acquired dementia, whatever, you're still just as precious to another human being and here on this planet as you ever were. And that's the process that we're trying to use science and humanism to bring forth in our medical world and in our world at large. Other people have gone on to prove this. If you look at the last bullet here, in this study of over 1,000 people from the Netherlands, delirium, again, an independent predictor of long-term cognitive impairment at 1 year, tripling the likelihood of severe long-term dementia. Now, the delirium as a fifth vital sign was the title today. Let's go all the way back to the 1950s when Engel and Romano wrote in the Journal of Chronic Disease about delirium, a syndrome of cerebral insufficiency. And they wrote, the deficiencies in education of many physicians ill-equip them to recognize any but the most flagrant examples of delirium. They seem to have little interest in and indeed often completely overlook delirium. The physician who's greatly concerned to protect functional integrity of the heart, liver, and kidneys has not yet learned to have similar regard for the functional integrity of the brain. This is a serious, perhaps tragic omission, say Engel and Romano, 1959. Years later, in 1978, this man began writing, Ned Kassem, about delirium in the ICU, and he began using Haldol for delirium. And for 50 years, for a half of a century, medical world used antipsychotics to treat delirium until we went on, and the reason they did that was that we showed this in the Yahya Shahabi paper in 2010, that delirium is a predictor of death. And the more delirium, the more death, and I've already kind of made this point. But we went on to study whether or not these antipsychotics help with delirium and published in the New England Journal in 2018 that they don't. Delirium is not made better by antipsychotics. Now, I still use antipsychotics in the ICU, but I don't use them to treat delirium. I use them to calm a patient, to prevent them from injuring themselves or others. I use them when I think somebody needs something that won't be a respiratory suppressant. So if a COPDer was in there or a heart failure patient having a hard time keeping their BiPAP mask on, I'm going to use an antipsychotic or an alpha-2 agonist because neither of those categories of drugs suppress breathing. But I'm not doing it saying, oh, Wes, you're now reducing delirium. But what does reduce delirium? What reduces delirium is the A2F bundle. The A2F bundle, or the ABCDEF bundle, is a bundle of 6 steps in ICU care that the Society of Critical Care Medicine, the largest critical care society in the world, says every patient every day should get the A2F bundle in the ICU. They do not say only if you're on a ventilator. They do not say only if you're on vasopressors. But we've proven this in patients on ventilators and vasopressors and in people in the ICU who aren't on those 2 extreme forms of life support. So what is it basically? A, analgesia. B, both. Stop the drug, stop the vent. C, choice of sedation other than a GABAergic drug. D, delirium management, measuring the CAM and the RASS, and then doing what you can to reduce the delirium. We use the Dr. Dre, which is BDRE, diseases causing delirium, drug removal, and environment. If every patient, every bed who was CAM positive, you just said, what are the diseases creating this problem? What are the drugs we should remove? And what environmental things should we change? That gets you 95% of the causes of delirium. E, early mobility. Early mobility is the best intervention by which we have to reduce delirium. It's been proven. Now, you can't mobilize somebody until you do the C, until you change the drug off of a GABAergic drug, or until you do the B, stop the drug. You see? So the E is intimately connected to the B, the C, and the D. Furthermore, you can't walk somebody if they're in pain. So you're back to the A. And what makes it easier to walk somebody? Have the family present. So now you've linked in the F. So this is all intertwined. And when we did this in an intertwined fashion in 6,000 patients in California, what we found was if you go on both these graphs, see the lines go up. On the left, the line goes up which means more survival. On the right, the line goes up, which means more freedom from delirium and coma. Okay, so more normalcy of the brain. And as you go across the x-axis on each graph, it's more and more compliance. We went in clinical practice, we want to get 80% or better compliance with anything that we think is worthy. So for any quality improvement program, I always say our target is north of 80% compliance. So if you're at 50% compliance, that's better than zero, but you're really not very well compliant with the bundle, are you? And besides that, 6,000 patients is great, but what about another 15,000 patients? Here we have 15,000 people. Look at the H's across the United States and Puerto Rico where we did this study. And now you have compliance on the y-axis. As you go up in compliance, you see that there is an improvement in ICU discharge. There's an improvement in hospital discharge. There's a reduction in death. As you go up in compliance, you see there's a reduction in coma, reduction in delirium, reduction in physical restraints. Now, if people are awake and not delirious, which I'm just showing you works, then they ought to complain of more pain. That's what we found. And I knew we'd find that because I want them back so they can say, doctor, I'm in pain, or I'm intubated and I can't speak to you, but on this pain scale, I'm at a 7 right now. Please get me down to a 2 or a 0. This is my favorite graph of this 15,000 person study, reductions in ICU readmission and reductions in transfers to nursing homes. Beautiful outcomes that we all would love to have in our ICU and which are available if we will but get north of 80% compliance with the bundle. Now, I can't show you all 400 papers that went into making the bundle, but there are north of 400 peer-reviewed manuscripts that went into making this bundle. But if I just plotted for you those in the top 3 clinical journals, the New England Journal, JAMA, or Lancet, you can see that there's a tremendous amount of support here at B and C, JAMA, New England, Lancet, at D and E, and at F, and for the importance of PICS in this world. So once we put all these things together, we wrote about them as a bundle. Now, the top quote there says, the A2F bundle, the sum is greater than its individual parts. And I was showing you that earlier, how these are all intertwined. Individually proven steps must be tested together to call them a bundle, says Don Berwick, who is the founder of the IHI, the largest quality improvement program in the United States. That's why we wrote about these separately and then together. So what is the bundle? It's an interprofessional approach. It's a change in the care process where everybody's involved. It's additional measurements. The delirium is our canary in the coal mine. We have to put forth the time and the effort to liberate people from the ventilator. We put forth careful attention to sedative use and time and effort to mobilize people and the family at the bedside, because this is the way that an entire person should be cared for, with the love and support of their family, and for us to see them as an entire person, not just a set of diseased organs. We need to convert humanism and science to magnify human dignity. I love this expression, cada persona es un mundo. Each person is a world. And in EDDB, I have many, many examples of people who felt more like themselves, more like a person when we treated them with the full bundle. This is an example right here. Mr. D was treated with the bundle, and so the very first day that he was extubated was this day. And you can see when I asked him, not what's the matter with you, Mr. D, but what matters to you. I call this switching the preposition. Not, Mr. D, here's what's the matter with you. Mr. D, what matters to you? And he said, I love my wife, Wanda, and you see her name is tattooed on his hand, and I want a beer. This is a beautiful way to follow his extubation, I think. This man here, Jaisal Pairut, wanted to be, he said to me, what matters to me? My Buddhist faith. And I ask every patient, do you have spiritual values that you want me to know that can help me be a better physician for you? And he said this, so we worked to get these 3 Buddhist monks from across the southeastern United States, from 3 different states. They came to be with Dr. Jaisal Pairut. This man said, yes, I have spiritual values and I want to be married I've never married the mother of my son. And you can see him crawled up in bed with him and her, and he was dying, and we conducted this marriage. It was beautiful. And so even sacramental things can occur in the ICU if we stop to treat a person as a human being. Bringing the talk to a close and having many minutes of questions for Q&A. I'm deliberately bringing this to a close early so that you can ask lots of questions. And when I'm done, I will unshare my screen so we can have a conversation. In COVID, we found something very dastardly happened. In COVID, at the beginning of the pandemic, if you look at this top line in this table, it says that 86% of patients with acute COVID were treated with midazolam. That was a striking deviation from what had been occurring just the year before. Historically, from 2000 to 2014, we had delirium rates that were in the 70 to 80% range. Once we implemented the bundle between 2015 and 2019, our delirium rates dropped by half, down into the 40 to 50% range. And this was proven in multiple different randomized controlled trials and cohort studies. But then when COVID occurred and we started using benzos again and keeping people behind the glass and not walking them or getting them off the ventilators fast. Now, granted, COVID is a long disease and it took us longer to get them off the ventilator, but we exacerbated that problem. And I'll show you data to support that comment in a second here. The delirium rates went back through the roof, over 80%, with benzo use over 80%. So I started getting letters from people all over the world, especially from Spain and Latin America, saying, Dr. Wes, this is a big problem. We have so much delirium in our ICUs right now with COVID, we think we need to study this. So they got me on Twitter. I'd never been on Twitter before, and I don't do it much anymore. But at the time, we advertised this COVID-D study, and within 2 weeks, we had 2,100 people enrolled into the COVID-D study, which we ultimately published in Lancet Respiratory. And the main two findings from this 2,100 patient study were that the drivers of delirium were overuse of sedation and underuse of family. And if you think back to our COVID ICUs, you know that that's what happened. We were overusing sedatives, we were underusing family, and we'd already proven that lessening sedation and increasing family was good. And here in COVID, we did the exact opposite. So it was a super dangerous time for us. We deviated from what I think is the most humanistic versions of care. It galvanized, though, our research efforts to do better going forward. And normally, if I was with you there in person, and sorry, I'm not, I would show you a video. Now, if you use your phone right now and scan this QR code, you can find that video. The video is just a 5-minute long version of me explaining what's the bundle, what happened in COVID, how can we get past it, and what do we need to do as a critical care community. In this circumstance, this video, you can also find it just by going to our website, icudelirium.org, and going to the survivorship endowment. I show you these because as all of you fancy people are there together thinking the great thoughts, what could be better than for us to focus all of our attention down on improving the acute and long-term approach to preservation of the human mind, which is to say, preservation of the human spirit. I will close by sharing with you my do's and don'ts in healthcare. These are just things that I wrote up, 6 on each side. Do put touch before technology. Do switch the preposition. Take a spiritual history. Teach and practice compassion, compatio, to suffer with. Take a knee. At the bedside, I often find myself on my knee. And the reason is that my pride is so great, I have to reduce it somehow. So I try and physically make myself smaller and make the patient bigger. And when I get on my knee, I'm at eye level with my patient. And it reminds me that I am there to serve them, not the other way around. I'm not there to try and build my career or to try and do something that makes me feel better. What makes me feel better is by human service. And then I remind myself to ask those 4 questions I mentioned earlier. What's his favorite, or what's your favorite food, music, pets, hobbies? And then I cannot think of you as a gray, depersonalized human being. I have to think of you in bright color. Don't. Don't overuse equanimity. Equanimity is a word that Osler made famous in his famous speech, Aequanimitas, to the University of Pennsylvania in 1890, where he said, be even keeled, pull back a little bit. But I overused that virtue, that asset, and it became a liability for me with my patients, because when I was pulling back too far, they no longer had a healer. What they had was an automaton who was good at intubations and central lines, but not a healer. Don't separate loved ones like we did in COVID. I never want to live that way again. It was anti-medicine. Don't be satisfied with benevolence. Benevolence means intending good. I don't want to intend good. I want to actually do good, which is beneficence. Don't allow malignant normality. Don't fear failure. And why rob myself of joy? The joy I get from loving other people, the joy I get from saying, can I provide mercy? So the question is, can I pursue a quest to find the person in the patient using humanism and science? And so I'll stop here by saying that what I want to do as a physician is use my science to be a better healer. And to do that, I want to deliver mercy. And the way that I can deliver mercy is simply by doing a better job of saying, am I willing to dive into the chaos of another person's life and provide lifting and healing? And if I can do that, if I can dive into another person's chaos and provide lifting and healing, then that is a way for me to be a better physician, a better healer, and just a better person who's diving in with the families. Thanks so much for your attention and time. I'm going to unshare now, if I can get to it. Can't seem to find.
Thank you, Wes. This is Peter Gay. Can you hear me?
Yes, I can.
Can you hear the applause of the audience that is here in awe of your talk right here that very much was appreciated? Sorry you couldn't be here with us, but if you can hear me well, I'd like to take advantage of having you on our screen here and ask you a few questions. I'm going to start with the fact that, you recognizing that we learned something and then another tragedy takes preference, and then we go completely backwards as we did in the COVID epidemic, and we substituted one delirium-inducing thing for another. But one of the things that's very difficult to resolve in our hospital is the fact that once the delirium is there, and as it often does in our hospital, an RRT is created. So they rush out to the bedside and they decide whether they need more monitoring or not. And then most of the time, they still leave them on the floor, and then it's a behavioral problem. It's not a patient problem. They have to control the patient, and what do? Well, it's usually like you say. I call them the peen approach. They give them quetiapine, they give them mirtazapine. The peens are now taking over, and now they're behaved, and now that we can get them to a nursing home, it's not our problem anymore. So I see the tragedy of creating a behaviorally managed patient in a delirious state just so that we can manage them in the hospital. But how do we get them moved along in that now prolonged delirium track that we've created in the hospital?
I love the question. And can you hear me okay?
We can.
Okay, and you've unshared my screen, so I'm full screen?
Yes.
Okay, I just didn't want to be a little box. Okay, so imagine, I love your example, and I never heard the peen approach before, but I love that. That's a good one. I will give you attribution. In the ICU, let's do 2 patients. One is in the unit where I'm the attending. And by the way, I'm very much a bedside ICU doctor. I'll be on service in 2 weeks. When I'm the attending in the ICU, if that person with the RRT, rapid response team, brings them in and admits them to me, then I'm going to say to myself, okay, they just got intubated, or they, or they're not being intubated, but they've been sedated on the floor, and now they're here. I'm going to say to myself, and the PharmD and the rest of the team, okay, let's employ the ABCDF bundle. Let's see, is their pain controlled? Okay, fine. Their pains, no, their CPOT is a 6. Well, let's get that down below a 3. or let's say it's already pain controlled, then what's the B? Both SATs and SPTs. Are they on a vent? Can I stop the sedation? Because I don't want them to get any more sedation than is required. And my goal is not to sedate the patient. My goal is to have the patient awake with me and not delirious. And I know that the drugs are deliriogenic. Okay. And then see what choice of drugs have we given this patient. Maybe there's too many peens on board. By the way, be thinking this could be done on the floor too, because I'm getting to that second. And then E, early mobility. You know what? Somebody says, well, you know what? This woman's weak. She's had neck fash. She's got poor muscle strength. There's no way she can walk. Yeah, I don't need her to walk. I just need her to get out of the bed, because 1 foot today and then falling into a wheelchair or a bedside chair becomes 2 feet tomorrow, becomes 8 feet the next day, becomes 10 feet the following day. I have a picture of a woman who did have neck fash. She had most of her face taken off. Her name is Janet Keith. And on the very first day that she was extubated, after about 10 surgeries and double-digit days in the unit, I have a picture of her about 60 feet from her room, walking on her own 2 feet by herself. And you know as well as I do that had we not been walking her the previous multiple days when she was on the vent, there's no way she could have done that. She would have been so weak and so debilitated with so much ICU acquired weakness that she would have barely gotten out of the bed. The reason that I have this picture, and I use it all the time, is that was the first day she was off the blower, and she's so far away from her room. Well, that speaks to the point that you have to start early. And by the way, all the studies that work, if you look at my hands right here, and this is day 1, 2, day 5, day 10, all the studies that showed that early mobilization is successful take place in the first 4 days. That's when mobility starts. Whenever the studies are negative for early mobility, the mobility is starting here after day 5. So late is too late, and early is what's required to get people off of the ventilator and out and walking in the ICU to where they have better functional survival. Now, take everything I just said to your example and go to the floor. So the person doesn't come to the unit. The RRT, they get peened up with the drugs, quetiapine, whatever, and they're still on the floor, so I don't have access to them. What if your hospital, my hospital, had said, there's a QI program on the floor. We need to do this on the floor. Adapt the bundle concepts, which is basically wake them up, get them out of bed, have the family there on the floor too. So we don't think it's okay to do this in a unit and not do it on the floor. We have to do it in both locations. That's my thought.
Appreciate that. He can hear you if you come to the mic, so if anybody here has questions, it's easier. If you're timid, you can ask me and I'll transfer. You want to come up to the mic? He can hear you, or if it's easy.
Yeah, don't be bashful. Let's ask some questions here. We have time.
Yeah. I'll make this easy for you, Mike.
Okay, thank you. A stiff knee here. All right. Wes, it's Mike Niederman. Congratulations. That was an inspiring talk. Nice to hear it. You've done a lot of phenomenal work, but one of the things you didn't touch on, apropos your baricitinib studies, what have you learned about mediators and the causes of delirium and the potential of intervening, even pharmacologically, in a positive way?
Yeah, that's a great question, Mike, and thanks for being there. Let me see if I have, yeah, here we go. I'm going to share a slide when it pulls up. I want us to be thinking about that immunomodulation can be a beautiful way of reducing delirium. And in COVID, when we used baricitinib, the reason that we did that was because we knew it was an immunomodulator across multiple types of areas. Now, if you look at, can y'all see this graph now?
Yes.
So here's acute COVID and here's long COVID. In acute COVID, we used Bari and it worked. By the way, baricitinib has the highest survival advantage of any drug in COVID. The survival advantage in Bari was greater than steroids. And it was the first immunomodulator FDA approved for COVID. Now steroids have been approved as well. But this was before Toci and other drugs. So everything that's red on this graph is something that Bari hits. IL-1 beta, IL-6, IL-12, 27, TNF alpha, PTX3, CCL7, And then over here, the interferons, CXL 11, 9, 10, and 11. So I'm going to unshare now, but the point is that across multiple different places in the human body, an immunomodulator like this can do wonders for people with chronic diseases and with acute diseases. I mean, Mike, you've made your career helping us understand how to reduce death and injury from pneumonia. And we know that's a widely inflammatory illness. And there are interesting data about steroids. I'd love to hear your thoughts about immunomodulation and pneumonia. What we're learning in these IACCs, infection-associated chronic conditions, which are disease states that occur after an acute illness. Long COVID, long Lyme, fibromyalgia, ME/CFS. I'm on the committee with the National Academy of Medicine to redefine long COVID. And our figure that we created says long COVID is a disease state that is in the family of IACCs, infection-associated chronic conditions. And we believe that it is likely mediated by a dysregulated immune system. And that's why we're going to do this randomized controlled trial, phase 3 study of Barry. Now, as you're sitting here, I want you to remember me saying this. In 3 years, we may publish this study and maybe Barry didn't work. Maybe Barry doesn't improve this IACC. The truth of the matter is either answer matters. I'd love to hear a comment back, Mike, perhaps about this, but if Barry helps, then that's great. We understand that immunomodulation with the JAK-STAT inhibitor helps. But if it doesn't, I think that's also super informative that we know the immune system is dysregulated, and yet modification over 6 months didn't make the disease state better, so we better look elsewhere. So those are my thoughts about this.
My father used to say, he never loses. He either wins or he learns. And that may well be the result of your trial. There are other questions here? Barry? Or Mike? Frank?
Dr. Ely, Frank Overdyke, that was excellent. I have a question for you. I'm delighted we have a new fifth vital sign. As an anesthesiologist, we all remember when pain became the fifth vital signs in early 2000, and we had a lot of unintended consequences as a result of pain. But pain treatment, like you said, really, really important. Delirium, where are we on recognition, not only in the ICU, but like you said, these are best practices that need to bring into the ward. Where are we? We do a level of consciousness assessments on the ward. But is delirium as front and center as it should be, and how do we get there?
Thank you. I appreciate your question and comment. It is not as front and center as it should be. As I said at the very beginning, it's a predictor, an independent predictor of death, length of stay, cost of care, and long-term brain dysfunction, and we don't measure it nearly enough. So we are doing some research right now. I'm working with a mentee whose name is Shaniqua Williams-Roberson. She is a physician who trained at Hopkins, MIT, and Penn, and we're doing work with the EEG. Massimo and Biss have done previous work with the EEGs in the ICU. That has not really, that previous work didn't really pan out. Shaniqua's work is taking us to the next chapter in this area of saying, can we have a biomarker via brain, brain waves in the ICU where we can monitor this on a more continuous basis, the way we do pulse oximetry for peripheral circulation, oxygenation, et cetera. So that's what we're working on, is to see if we can have a more readily available continuous monitor for delirium and brain injury. But in the absence of that, I want to say that we already have what we need to be able to recognize delirium. I mean, it takes 20 to 30 seconds max to find out if somebody's delirious. All we really need to know is, can they pay attention? And the easiest way to do it, I just say, Miss Smith, squeeze my hand. Now, Miss Smith, I want you to squeeze only on the letter A, okay? So let's practice. A. All right. S. A. V. E. A. H. A. See, so she's already stopped squeezing. That right there is inattention. She got the command at the beginning. Her brain went out, and she had attention for 5 seconds, but not for 10 seconds. That is the way the CAM works. So all you have to do is go and have this attention screening exam via 10 letters. You can spell abracadabra, you can spell save a heart, you can spell a bad, bad day, or you can spell Casablanca. That's easier to remember. Spell Casablanca, and if the person gets 8 out of 10 correct, squeezing on an A's, not squeezing on non-A's, then they are attentive. If they get less than 8 out of 10, they are inattentive, and that is the world of delirium. And then we need to do the Dr. Dre, diseases, drug removal, environment. We can make it simple, but we've got to change the culture to value this so that every patient every day gets monitored for delirium.
Good morning again, Dr. Ely. This is Tim Morris. Thanks for that talk. That was really amazing. I wonder if, since the focus of today and tomorrow is sort of on the few hours or the day before catastrophe strikes, the just prior to the code or something like that. I wonder if we could take any of the tools that you've used in people who are, sort of post-catastrophe or during catastrophe and apply them to the time just before. For example, would daily screening for delirium people who are not critically ill, who are just in bed and have 1 or 2 warning signs, do you think that would be helpful to try to prevent things in the future?
That's a great way. I know we're just about out of time here, but let me just say that that's the whole hope for me, is that I went into this thinking, as a doctor, I'm not doing my job. I am distancing myself from people. I'm allowing them in the unit to have their brain off, and I'm thinking that's okay. So we created these tools, this very simple hand squeezing way of figuring out, Casablanca, they only got 5 right, they're delirious. And now what I want us to think about is this: what if every patient every day, as is recommended by the guidelines, by the way, it's already recommended. We already have these data to say this is valuable and doable and should be done. Was screened like this. Then on Monday, when they come in the hospital, we screen them on Monday and Tuesday, and they're not delirious when they get in, but on Tuesday they are. Well, that's your canary in the coal mine. The person switched from being not delirious to delirious, canary in the coal mine. Uh-oh, Houston, we have a problem. Their brain is now off. See, the brain is a very sensitive barometer of goodness in the body. And when the brain turns to inattention or delirium, that's a sensitive indicator of badness. So then we have to say to ourselves, let's check a white count. Let's check a chest x-ray. Are they getting pneumonia? Are their electrolytes gone bad now? Are they too immobilized? Do we need to get them out of the bed and walk them? Where's their family? How can we get them to the bedside? And do something to turn that around again. Or sleep. Was sleep wrong? Did they not get sleep last night? Let's make sure tonight we don't interrupt their sleep. Let's give them at least 4 hours of uninterrupted sleep, because absence of sleep is deliriogenic. So I love what you just said. I think that we can change the culture in our hospitals to say, on the wards and in the unit, we're going to check every patient every day with a 30-second screen to see if they're delirious. And when they convert to delirium, we're going to do something about it.
One last question here.
Hi, Wes. This is Barry Meek. Wonderful talk. It was fantastic. So you mentioned just a little about quality improvement or adherence to the A to F. How are we currently monitoring that in our individual hospitals, or are we?
Different hospitals do this different ways, but let me give you a couple of options. Epic and Cerner both have built in to the Epic and Cerner basic platform in critical care, and it's available on the wards, a way to track delirium live, real time. So if you, for example, let's say, Barry, that you are in XYZ hospital and you go back and you say to your team, are we monitoring delirium every day? Because this is the 5th vital sign. Like, everybody should be getting this checked, and it will save us money. Because if we don't do it and they get sick, they're going to have a longer stay. It's going to cost more. So we can save money if we check it. So the bean counters will love you. And they say, well, we don't have that in our Epic. You could say, well, I know for a fact that Epic has already built this. So let's talk to our people, our Epic College, our Epic University people, and let's unfold, implement the bundle that has the AWF bundle, and we can make it live so that each nurse every day documents the delirium. And then, but here's the second key piece. On rounds, we have to say to our staff, our nursing staff, or our pharmacists. In our ICU, it's the pharmacist that does this. They report to us what's the CAM and the RAS and what's the target RAS. We actually have 4 things they say. I call it the brain roadmap: target RAS, actual RAS, CAM, and drugs. And if you say the target RAS is -1, the actual RAS is -3, they're CAM positive, and they're on fentanyl, then I can say, well, their target RAS was -1, but their actual is 2 off. We allow 1 off, not 2 off. That's too deep. And they're delirious, they're CAM positive. I need to stop that fentanyl, get them out of bed, do the Dr. Dre, and it just gives you a treatment roadmap. So you can activate this within Cerner or Epic, have it live, have it documented. You can track your compliance over time. Once a month, at the beginning of every month, we report our compliance. Have we dipped below 80% compliance with doing the CAM, with RAS targets and actuals, and so on and so forth? So you can build this QI, and we at the SIB Center are happy to help you. If you reach out to us, we will help. We have lots of people to help.
Wes, I want you to hear the applause for your wonderful presentation.
Thank you. Thank you all. I appreciate you.